Special consideration while using high-profile and extra-high-profile implants. The following recommendations are based on the author's clinical experience in the surgical management of over 650 patients during awake breast augmentation surgery, while working almost exclusively with Allergan Natreo Style 68 high-profile saline and Style 45 extra-high-profile silicone implants. This author's recommendations are based in part on data from a study collected and published in the American Journal of Cosmetic Surgery, September 2012. The title of the peer-review article was Tumescent Anesthetic Breast Surgery, or TABS, Primary and Secondary Breast Augmentation Surgery in an Office-Based Surgical Center. Based on the TABS study, the data collected was from December 2008 to November 15, 2011. All the procedures were done as awake procedures. All implants were placed in a subpectoral plane. The augmentations included 448 primary augmentations and 56 secondary breast augmentations, with the use of 489 Natreo Style 68 high-profile implants and 13 Natreo Style 45 silicone extra high-profile implants. The results of the TAB study were as followed. There was a 4.2 incidence of capsular contracture, grade 3 or 4, listed in the study. The complication rates were similar to data listed by the Allergan Corporation. However, the rate of extrusion was slightly higher, with a 0.79% rate of extrusion compared to 0.6% as listed by the Allergan Corporation. Post-study data evaluation. The case series was extended from December 1, 2008 to May 15, 2013 and included 652 patients. All surgeries were done as awake procedures. All implants were placed in a subpectoral plane. All were placed using either Style 68 high profile or Style 45 extra high profile implants. Post-study results. The rate of capsular contracture was found to be below 7%. Complication rates were found to be similar or better than those published in the literature, except in cases of implant dehiscence and extrusion. What is the difference between capsule dehiscence and implant extrusion? For our purposes, an implant capsule dehiscence is when the capsule ruptures, allowing for the herniation of the implant through the capsule defect, but not through the skin. An implant extrusion is when the implant ruptures through both the capsule and the skin. The results of our study showed 4 cases of dehiscence and 4 cases of extrusion. These rates appear to be higher than the published data provided by the Allergan Corporation. Further, the literature fails to show a distinction between the incidence of dehiscence and extrusion, which could mean that there's an underreporting of these particular events. All cases of dehiscence and extrusion in our study were associated with Baker grade 3 or 4 capsular contracture. The fact that all cases of dehiscence and extrusions in our study were associated with grade 3, grade 4 capsular contracture is considered to be significant. It is believed that the risk of dehiscence and extrusion is higher when using high-profile and extra high-profile implants as compared to moderate or lower-profile implants due to the significant increase in projectile force to implant diameter ratio, which is produced by the capsular contracture. The higher incidences of these events as compared to moderate profile implants are believed to have been caused by the higher projecting implant shape. Further, their association with capsular contracture does not appear to be coincidental. As you can see in this diagram, grade 1 and grade 2 capsular contracture does not significantly distort or change the projection of the implant. However, as a capsular contracture progresses to grade 3 and 4, the implant diameter is decreased, which in turn causes a significant increase in the projectile pressure against the overlying tissue layers, especially in the case of high-profile implants. Over time, the capsule implant projection forces can cause a separation or dissection of the pectoralis muscle, leading to a spontaneous dual plane 1, 2, or even 3 dissection. The implant can then extrude through its capsule as the capsule ruptures. The effect produces a significant thinning of the overlying tissue as the implant herniates through its capsule defect, causing a dehiscence of the overlying tissue. With little or no resistance from the overlying fatty tissue and skin, the defect continues to dehisce, signaling an imminent and irreversible extrusion through the skin. The extrusion through the skin can occur a few days or weeks later as the ruptured but still contracting capsule continues to compress the implant from the superior and lateral sides, eventually causing the skin to completely thin out and break down, producing an extrusion of the implant. In this drawing, the left breast shows the natural appearance of the implant in a modified dual plane 1 position. On the right, however, we see the spontaneous dissection of the pectoralis muscles caused by a capsular contracture grade 3 and 4. We also see the herniation and rupture of the capsule, which is a precursor to the extrusion of the implant through the skin. In our study, 7 out of 8 of the dehiscence extrusions occurred between the NAC and the inframammary incision, and not through the inframammary incision itself. This is believed to have been due to the relatively strong incision scar formed by the reapproximated pectoralis muscle incision line, as well as suturing of the pectoralis fascia to the intercostal fascia. Therefore, in the presence of grade 3 or 4 capsular contracture when using high-profile or extra-high-profile implants, capsular contracture should be more aggressively managed as compared to lower-profile implants. The current recommendations based on the TAB study are defined into 2 categories: the preventative management of capsular contracture and the therapeutic management of capsular contracture. Preventative management of capsular contracture with high-profile and extra-high-profile implants. It is recommended that based on their projection to diameter ratios, that all high-profile and extra-high-profile implants be placed in a submuscular plane, with a complete submuscular plane positioning providing the maximal coverage by the pectoralis muscle. A no-touch technique should be maximized whenever possible, especially in the cases of placement of silicone implants where the Kelly-funnel can be of a significant benefit. Massage exercises should begin approximately 24 hours after surgery, and compression exercises where the patient is resting prone directly on her breast should begin approximately 7 days after her surgery. Antibiotic irrigation during the surgery should be considered, such as triple antibiotics using bacitracin, Ancef, and gentamicin. PO antibiotics should also be considered, such as Augmentin 875 PO BID, beginning 3 days before and continuing for 7 days after surgery. Iricept OR should be used during the surgery, especially as a complete substitute for the triple antibiotic irrigation solution. A prophylactic use of accolate at 20 mg PO BID times 3 months. Vitamin E at 1,000 mg per day PO times 30 days. Milk of thistle at 1,000 mg per day PO times 30 days. And omega-3 at 2,000 mg per day PO times 30 days. If the preventative management of capsular contracture is not successful and a patient is diagnosed with grade 3, grade 4 capsular contracture using high-profile implants, the following protocol is recommended for the non-surgical management of this situation. The use of prednisone is recommended on a sliding scale over the next 28 days, first to decrease the amount of discomfort and also decrease inflammation or inflammatory response, as well as to soften the capsular contracture itself. The use of accolate, vitamin E, milk of thistle, and omega-3. We also continue with the use of massage therapy as well as pressure exercises, and we have recently considered the addition of two medications, Pavabid, which is a smooth muscle relaxer, and profenadone, which is an antifibrotic medication. Vedas Castillo recently published a paper in a study with the use of profenadone, which is a wide-spectrum antifibrotic medication. In that study, with the use of 1,800 milligrams POQ day, in 20 cases of capsular contracture grade 3 or 4, 95% of the patients showed a reduction to capsular contracture grade 1 following 6 months of use of the medication. One case showed a relapse, which was attributed to steroid use and overexercise. These results are promising, with the possibility of adding this particular medication for the prophylactic or therapeutic management of capsular contracture. Regardless of the results of a non-surgical management protocol for the treatment of capsular contracture grade 3, grade 4 when using high-profile and extra high-profile implants, the recommendation is a surgical correction. The surgical management protocol begins with the use of the non-surgical management protocol for up to 30 days prior to surgery. Medications in using this protocol should continue for up to 3 months following the surgery, except in the case of the use of steroids, which should be discontinued preoperatively. Accolade or Singulair should be continued prior to the surgery and postoperatively. The surgical management portion of the protocol includes 3 days preoperative use of antibiotics followed by 7 days postoperative use of prophylactic antibiotics. We prefer to use either Augmentin or Cipro. The actual surgical component includes either undergoing a capsulotomy, which is scoring of the capsule, a partial capsulectomy, which is the removal of portions of the capsule, or a total capsulectomy, which is not recommended as an awake procedure. Capsulotomy versus capsulectomy. Despite the fact that capsulectomy is the recommended surgical management of capsular contracture, the literature confirming its superiority in cases of subpectoral implant capsular contracture is severely lacking. The estimated recurrence of capsular contracture for both capsulectomy and capsulotomy is between 30 and 35%. In regards to the surgical management of subpectoral capsular contracture, capsulotomy or capsulectomy are both appropriate options when taking into consideration the risks versus benefits of each procedure. When deciding between a capsulotomy or capsulectomy and the surgical correction of capsular contracture, the following should be considered. A capsulectomy is not recommended when the capsule is thin or flimsy, the implant or the capsule is touching the skin, and in the cases of silicone, the silicone has migrated into the armpit, or major blood vessels and nerves are involved. In these cases, damage to healthy tissue may occur when removing the capsule. In consideration of a total capsulectomy, it has been associated with an increased risk of bleeding and is not recommended as an awake procedure. Therefore, capsulotomy or partial capsulectomies are the recommended procedures when performing a surgical correction of contracture as an awake procedure. Surgical management with the replacement of the implant and either capsulotomy or capsulectomy is recommended in cases where high-profile or extra high-profile implants are used. If a non-surgical protocol is initiated for the management of capsular contracture grade 3 or 4, signs and symptoms should begin to improve within the first few weeks, especially when using steroid therapy for the relief of pain and Accolade or Singulair for the softening of the capsule. However, even if a non-surgical management appears to be successful, it is important to consider the fact that a triggering event has occurred with the likelihood that that breast will always be sensitized to that particular implant. Therefore, capsulotomy or capsulectomy with the replacement of the implant is recommended.